Hello, and welcome to the Clinical Liver Disease video series. CLD is an official digital learning publication of the ASLD. I'm Maureen Whitsett, a transplant hepatology fellow at the University of Pennsylvania. This presentation is part of the ASLD video series, How I Approach It, COVID-19 in the Liver, Clinical Dilemmas. Today's talk is entitled, How I Approach It, COVID-19 and Autoimmune-Mediated Chronic Liver Disease. I want to discuss how we evaluate and interpret abnormal hepatic biochemical tests in the setting of COVID infection in patients with chronic liver disease on immunosuppressive therapy. We will review what sorts of tests to consider when evaluating the etiology of hepatic biochemical test arrangements which can occur with COVID-19. And we will discuss how one might manage immunosuppression for these patients who develop COVID-19. Our patient is a 55-year-old woman with a long-standing history of PBC autoimmune overlap syndrome without cirrhosis. Her disease is well controlled on mycophenolate and ursodeoxycholic therapy, with baseline alkaline phosphatase ranging 200 to 300. She was hospitalized about 1 to 2 months prior with COVID-19 pneumonia. During that stay, she had a severe acute hepatitis with peak AST of 680, ALT of 391, alk phos of 439, and T-bili of 1.9. Her mycophenolate was briefly held. She received initial antibiotics, followed by hydroxychloroquine, low-dose prednisone, and supplemental oxygen. Her hepatic biochemical tests improved but did not normalize. Since discharge, she had developed worsening jaundice, fatigue, and pruritus. She was taking prednisone 10 milligrams, ursodeoxycholic, and mycophenolate had been restarted. Her hepatic biochemical tests were notable for a bilirubin of 9, AST of 251, ALT of 295, and alk phos of 348. MRI MRCP did not demonstrate cirrhosis, parenchymal, or biliary abnormalities. Elevated hepatic biochemical tests have been reported for COVID-19 infection in patients with and without chronic liver disease. We think that liver test arrangements can occur in COVID-19 due to direct viral effect on hepatocytes, the inflammatory milieu or cytokine storm, hypotension with shock liver, myositis, DILI. However, when a patient also has underlying liver disease, we need to be able to assess underlying disease activity. We don't truly know if COVID-19 infection actually exacerbates cholestasis in patients with certain chronic liver diseases. However, it should always be considered. But when you do have a patient with known CLD and COVID infection and liver tests are abnormal, potential considerations for the etiology of abnormal liver tests include decompensation of liver disease or acute on chronic liver failure, worsening cholestasis and known biliary disease, or a disease flare. So in patients with autoimmune-related CLD and COVID-19, we need to understand whether or not there is a flare of underlying disease. With autoimmune hepatitis, we can consider elevations in IgG levels and ALT as surrogate markers of disease flare, and possibly consider elevated IgG4 levels for an IgG4-related cholangiopathy. In patients with intra- or extrahepatic biliary disease, such as PSC or IgG4, we may appreciate paraductular enhancement or could appreciate worsening stricturing disease with biliary dilation on an MRI MRCP. This is not particularly helpful in our patient, as it is quite rare to see biliary disease in PBC autoimmune overlap. And while an MRI MRCP can be helpful, one important consideration to make is that there is risk of exposure to staph and other patients when we transport this patient down for imaging. Thus, we would only recommend obtaining an MRI MRCP or any imaging requiring transport if there were a strong suspicion of cholangitis or biliary stricture which may merit intervention. You could always start with a bedside right upper quadrant ultrasound initially, and if any significant abnormalities were noted, proceed with next step imaging. When should liver biopsy be pursued? We have liver pathology from autopsy series of patients who died from COVID, which demonstrate a wide range of nonspecific findings, such as steatosis, inflammatory infiltrate, necrosis, diffuse thromboses, and fibrosis. So, for a patient without underlying liver disease, there may be very low utility in a biopsy. However, if there is a question of whether or not there is a flare of underlying chronic liver disease, and it could potentially change management to know this information, a liver biopsy may be quite helpful. It is important to note, though, that there is a potential for inflammation to obscure etiology specific histologic findings. As we know, a liver biopsy is a procedure which carries potential for complications, and its utility must be carefully determined in the setting of COVID infection. Many of these hospitalized patients are on systemic anticoagulation, either prophylactic or therapeutic dosing, and thus the risk of bleeding must be taken into consideration. Additionally, the risk of unnecessarily exposing staff and potentially other patients should always be considered. There is some controversy regarding management of immunosuppression for patients sick with COVID 19. Anticipatory reduction in baseline immunosuppression in those without COVID 19 is not advisable, as a sudden cessation of steroids or antimetabolites may lead to a flare of underlying disease. For patients on chronic steroids who are ill but not requiring oxygen therapy, it is crucial to adjust steroid dose so as to prevent the development of adrenal insufficiency. As per the Recovery Collaborative Group data, dexamethasone should be considered if requiring supplemental oxygen or mechanical ventilation. Lastly, one may consider lowering the dose of antimetabolite medication before reducing the prednisone. Because of the great concern for a flare of her underlying liver disease, a liver biopsy was pursued. It demonstrated mild bile duct injury, moderate inflammatory infiltrate with focal interface hepatitis, and mild cholestasis with areas of necrosis. Thus, this was consistent with the flare of her underlying PBC autoimmune overlap. Her prednisone dose was increased to 20 milligrams, and over a few months' time, the patient experienced a significant improvement in her liver tests. On behalf of all of us on the CLD team and at ASLD, I hope you found this case discussion on the evaluation and management of patients with autoimmune mediated CLD and COVID 19 useful. For more information about liver disease and COVID 19, please visit us at www.cldlearning.com. Thank you for watching.